Welcome back to NalaTalk, where we discuss updates on the field of genetic testing, especially its implementation in clinical settings. My name is Fadhli, the product lead and pharmacist in Nalagenetics. And as always, we are joined here with Dr. Esther, the doctor in Nalagenetics, where we'll be discussing something sensitive but important in the field of depression, especially the use of genetic information in treatment of depression. Hi, Esther, how are you?
Hi, good. How are you?
I'm good.
Yeah, such an important topic, right?
Yeah, it is.
Yeah, I thought I'm going to start with just talking about maybe the prevalence in our community and how pandemic has sort of affected it, and the kind of burden that it has on the people who suffer from depression. So I have some stats here. So about 16 million people, actually, age 15 and older, have displays symptoms of anxiety or depression. That's in Indonesia. So that's pretty significant. That's a lot of people. But I think especially in the Asian population or just the culture, we don't talk about it enough, or there is sort of lack of awareness and understanding. And people just kind of shove it under the rug. People don't really talk about it. It's all about the just hustle mentality, just get over it, like just be thankful. And we don't talk about our feelings, that sort of thing, sentiment. So just want to highlight that it is very important, especially during the pandemic. We see rise in the symptoms of anxiety and depression, substance abuse, suicidal ideation, so we just sort of want to encourage all of our listeners today, whether you're health practitioners or you don't have any medical background, just to keep that in mind, to do a check-in with yourself and just see how you're going mentally, isn't it?
Yeah, it is. Especially in our Asian culture, where everybody aren't really open to their emotions, right? And displaying some sort of like negative emotions like sadness or anxiety could be seen as something that is a kind of weakness, right? I think it's about high time that we actually focus on talking about this with increasing isolation, where we have to make a lot of effort to actually talk to people now that we are, most of us are like stuck at home, unable to go out and talk to each other as per usual. But talking about depression, Esther, there's a lot of people saying that they have depression. A lot of people writing about depression. What is depression exactly in a medical term?
Yeah, no, that's a good question, because I think like people will say that quite casually in conversations, or they'll be saying like, oh, I think he has depression, or don't be so depressed, without really sort of knowing what it meant. So depression is actually just sort of a broad term that people use. But if you want to be more specific, sort of clinically, we have what we call a DSM-5 criteria. So it's basically like the holy grail, kind of like the Bible or any sort of holy book that people use to define depression, sort of the clinical depression, and one being a major depressive disorder for which there's a specific criteria of the symptoms that can include a depressed mood or a loss of interest, sort of for most days for at least 2 weeks. And there be a variety of other symptoms like weight loss, or weight gained, decreased or increased appetite, sort of reduced physical movement, fatigue, feelings of worthlessness, guilt, unable to concentrate properly. And of course, if you have sort of thoughts of self-harm or suicidal ideation, that is very important to be taken into account as well. And my main point would be that it is a diagnosis that is made by a healthcare professional. So it's more than just you being sad, for one day and you get over it, but it impacting your life. So you're unable to function properly, like school or at work, or sort of just interacting with your families and your friends, affecting a lot of aspects in your life. In which case, we highly recommend for you to go to your healthcare practitioner. Like it could be from your family doctor, and then be escalated to like a psychotherapist, and then like to a psychiatrist, whichever way they think it's appropriate. Yeah.
Yeah. So like summarizing a little bit from what you say is probably the two hallmarks of like depression would be its chronicity. It spans over a long period of time. It's not like if I'm feeling sad today, I'm depressed. And second is that it will actually affect your day-to-day activity quite significantly. Like you can do your activities as per normal. Maybe we can take a little bit, because depression, if we talk in the layman terms, it feels a bit subjective. So maybe we can explore a little bit in terms of basic science.
Yes, please do.
I have graduated from pharmacy for quite a while now. Back then, when I was studying in school, depression is all about its serotonin, right? The fact about, if the listeners here are interested, serotonin is one of the neurotransmitters that is being used in the brain to deliver message, sort of like its messenger. There's a lot of types of neurotransmitters besides serotonin, but one of the important neurotransmitter for depression was identified as serotonin back then. So what we try to do, or rather, like what happens when there's a patient with depression, is that there will be a reduced serotonin activity inside our brain, such that it can also cascade into the feelings of these what depression brings. So basically, the medications that we use focuses on increasing that serotonin level with 50% like hodgepodge success rate. Sometimes it succeeds, sometimes it fails. But after reading through a little bit more, actually, science has progressed quite a few steps ahead now that we have identified several other pathways that actually can cause or help or exacerbate the symptoms of depression. So what we found out is that besides serotonin pathway, there's also like the noradrenergic pathway, as well as the dopamine pathway, which means that with these new pathways being identified as the cause of depression, there's a lot more of drugs with different kinds of mechanism of actions being identified as effective to treat depression. So yeah, it's quite interesting that we have actually expanded so far, the information expanded so quickly over these past few years, which is quite good. So
yeah.
What do you think, Esther?
Yeah, no, definitely. I mean, it's good that that science always sort of expanded, and that we always kind of corrected on, actually, the thing that we thought we knew. Yeah, cross that. Just always coming up with new things, but that's just the way the world works. And hopefully, like what you mentioned earlier, sometimes it can be tricky or challenging for psychiatrists to dose the medications, given that there are so many factors at play, sort of in the depression itself, and how kind of it manifests. And there's a lot to be understood about the disease and the underlying sort of pathophysiology. So I think mainly for MDD, or major depressive disorder, the guidelines for therapy, at least when I also went to med school, would be like to obviously try to quantify it. So whether it's sort of mild, moderate, and severe, and we have sort of validated tools in order to do that. That is usually done by the psychiatrist. And from then we can go, like if it's quite mild, then usually people can be referred to have sort of psychotherapy. It could be like a cognitive based sort of therapy model. But if you if that's not really effective, or that you have sort of the moderate kind of severity of the illness, then you probably get trialed on antidepressant, for which the first line is usually an SSRI or a serotonin. Serotonin.
SSRI, selective serotonin.
Selective, that's right. I was like,
yeah.
Selective serotonin receptor inhibitors. Like you said earlier, it's to increase the levels and prevent breakdown, or like premature breakdown of the receptors.
the neurotransmitters. Actually.
They're neurotransmitters.
So it's interesting, right? So when we talk about depression and antidepressants, I've heard quite a few stories that people are like afraid of these kind of words. Just one of that is because they're afraid that if they started on this kind of medicine, it can cause like ketergantungan or addiction, dependency. But it's like putting everything in one lump, then, right? I was thinking.
Yeah. I mean, you always, like with medications, right? As clinicians, like we always want to sort of balance the risk and benefit of being on the medication. If it's so significant, the illness is so significant that you can't function like in your day-to-day, maybe you can tolerate a little bit of side effects, like I think what a lot of people are concerned about. But if it's quite mild and you kind of want to go to try out like a psychotherapy to begin with, like you're more than welcome to. Like you don't want to go straight into medications, that's perfectly fine, because usually as clinicians we work with the patients as well, want to provide sort of patient care therapy. So we would sort of give our recommendations, and if we think that it's still reasonable for them to have a combination of kind of CBT and medications, that's perfectly fine. But if it's quite significant and we think that you just definitely need to go straight onto medications, then we would definitely advocate for that. But maybe can you explain a little bit about, you mentioned some people don't get relief with the first SSRI that they're put on, or the first antidepressant that they're put on. Why, like scientifically, why would that be the case? Like, what are some of the underlying reasons of this phenomenon?
Right. Yeah. So I've mentioned previously that we initially thought that the pathway for depression is solely due to the serotonin. So it's just because of one lever. So if you have reduced serotonin activity, of course, what you want to do is increase serotonin activity, and theoretically that would work, and it would mean that your depression symptoms will go away. But actually, in real life, that only happens in about 50% up to 50% in the treatments. So we finally, after a lot of investigation, found out that this kind of there are two problems. One is that we weren't unable to bring the medicine over to the target such that it will increase the serotonin. That's one problem, which is a drug problem. Second is that maybe is the fact that the target has not been only serotonin all along, or the serotonin receptors in different people have different shapes. So you can't try to jam a key into another kind of lock, right? If it has one specific type. So it could be any of those two problems. And those two problems actually is defined as what you call as a pharmacokinetic problem, as well as a pharmacodynamic problem. It sounds like a mouthful, like pharmacokinetic, pharmacodynamic. But what does that mean? So pharma means drug, right? Kinetic means how that drug reaches the location that needs to be. Dynamic is that how that drug interacts with the target that they want. So how to get to that site, it's actually affected by transporters, by metabolizers, because these drugs, these are foreign objects, right? Foreign objects that is not supposed to be in the body. So the body will, they won't have they might not have the capacity to bring it over, and two, they will try to actively expunge or actively excrete this drug from their body, because it's a foreign thing after all. So the first one, it is unable to bring it over. No, the second one for the metabolism part, right? In some people, the metabolism of these kind of drugs is actually faster or slower. And it's actually defined by two types of genes. One gene is called CYP2C19. Another gene is CYP2D6. These two genes are what you call the cytochrome 450 family. This family is a family of metabolizing enzymes that is present in the liver. So these liver enzymes are actually responsible to break down a lot of different types of foreign substances, including the drugs. So CYP2C19 and CYP2D6 are the primary genes that breaks down the antidepressants, particularly SSRIs. So, for example, different SSRIs, maybe there's about 11 plus drugs that is included in this kind of family. Different SSRIs, even though they target the same receptor, which is the serotonin receptor, they are broken down by different kinds of cytochrome 450 enzyme. For example, like escitalopram or Lexapro is actually broken down by CYP2C19. So if you have an enzyme of CYP2C19 that is ultra rapid metabolizer, it could mean that the escitalopram might not have enough concentration in the body in order to exert its effect. While vice versa, if it's actually poor metabolizer, there might be overabundance of escitalopram in your body, and it triggers side effects. When that happens, you can switch to an SSRI that is being metabolized by another enzyme, maybe CYP2D6, for example, which is like paroxetine or fluoxetine. So that's one part. The second part, it could be, is because the drugs are there in the expected concentration, but the fact that the receptors might not be as responsive as we predicted it to be. So we actually have also tried to categorize the different types of serotonin receptors, which is the HDR2A, and it also shows that in different kind of population, slightly different for conformation of these kind of receptors. There's actually some studies that shows that there are different. There's a significant difference between the receptor conformation as well as the efficacy of SSRIs between Asians and Europeans or Westerners. So that's quite interesting. And not only that, if we zoom out away from the serotonin pathway itself, there might be the reason why the depression symptoms are not solved is because it is not really affecting the serotonin pathway for this patient. It could be because it's a dopamine pathway is affected, or it's because of the norepinephrine pathway is actually affected. So yeah, it's actually a whole complex list of symptoms. So at least knowing a little bit about the existing pathway, which is serotonin, it actually gives a little bit clearer picture so that the doctor will have a better understanding of which drug to choose first.
Wow. Thanks so much. I feel like I was just sitting in a crash course about like it just brings back memories about how I used to like sit in lectures and learn about all these things, which are fascinating, but also, I mean, like for the patients, I guess it'd be quite frustrating, because there's a lot of these different factors that we don't know. And so, I hope that today's episode sort of can bring more knowledge and understanding and awareness sort of about mental health, specifically more about depression that affects so many people. I'm sure we need to talk about it more, because I'm sure if you just talk to the people around you, sort of in your circle, you find out that it had affected them at some point in their life, or it will. So just being more aware of this issue kind of allow you to, one, when you do experience it, what are some of the support and therapies that are available out there. And also you can be the support person that can sort of direct other people in case that they need your help. And we just want to say there is help out there. That it is possible to live a very good quality of life, even if you suffer from this. There's effective therapies out there, and even though sometimes the medications can be quite tricky to titrate or to just find the right one, let's have that hope that with the advancement of science, we will always work towards having a better knowledge, and hopefully that would lead to better discoveries in sort of the pharmacotherapy that we can give for patients for the treatment of depression.
Yeah, if I can add a little bit more, Esther. So I think mental health and also mental illness is seen a little bit differently, especially in Asian culture, right? People take mental diseases more personally than other kinds of diseases, right? If you have flu, you'll know that it's just a flu. You'll get over it after a while. But mental illness, usually people try to correspond it to a kind of a personal flaw or something that is not right in yourself, which I think is not a good way of looking at it. I don't know. Maybe if I could just push the needle a little bit to the right side to say that mental health or mental illness is the same as any kind of other illnesses. Like if it's the same as you having a flu, you having cold, or having like diarrhea or all kinds of other stuff. It's just a situation that it doesn't define who you are, and you can actually get better if you look at it from that kind of point of view. I think it will be very helpful in terms of your path to recovery and also working with the doctor. I think we should be, as Asians, also we should follow like this kind of like trying to change the way we look at these kind of diseases. Yeah.
Yeah, no, absolutely. Yeah. Thanks for saying that. And we hope that the more we talk about it, the less stigma there is out there, as well as you said, in the Asian population especially. And yeah, thank you so much for tuning in for another episode of NalaTalk. We will see you next week with another use case.
Thank you, Esther.